Established in 2006, Manitoba eHealth is a provincial program working with healthcare professionals to develop solutions that improve the delivery of care to patients in Manitoba. Manitoba eHealth works to provide solutions that integrate health systems across regions and care sectors, improve the efficiency and effectiveness of information and communication technology services, and create reliable and secure connections to health. Through this work, the organization continues toward the goal of establishing a province-wide electronic health record. This is the Data Center, the technical nerve center of Manitoba eHealth. Data and information collected and exchanged by the various eHealth systems flows through these servers. To demonstrate the positive impact eHealth solutions are having on patient care, we'll take you into the clinical environment to hear directly from healthcare providers and patients. The first phase of the Electronic Patient Record, or EPR, was activated at St. Boniface Hospital in 2007. Phase 2 followed in 2008, and a system upgrade was undertaken in the summer of 2011 to increase the capacity of the system to add more functionality.
I've been working with the EPR since the inception, and I was also involved with it long before the inception. The components that we use in the emergency, we use the EPR itself, which is where we do the entry of orders for patients and review of lab results. We also used patient tracking in the emergency department. The tracking board is a component that allows us to see the patients that are waiting in the waiting room and then also where they're located in the emergency department. What the EPR allows us to do is see the lab results in real time. As soon as the lab enters those data elements into the computer, we know they're there and we can see them right away.
We had a very unstable patient that was transferred to us from the emergency department. And the medical director of the hospital, Dr. Bruce Rowe, happened to be having two hats on that day. He was also doing his endocrinology. He's an endocrinologist. And he was on call, and he came up to the unit after a phone call, and he attended to the patient, and we got the patient the beginning of the treatment that she needed. He had to return to his management capacity. He was able to keep in touch with us through the electronic patient record. There was phone calls, but when I spoke to him on the phone, him and I were talking about the same information. He was able to see the lab data that was done. He was able to put in orders. We were able to carry out those orders, and we were able to stabilize that patient.
There have been a few instances where there have been upgrades to the system. So the EDIS and the EPR were offline for a number of hours. And no matter what people said before the system was offline, all you can hear is a bunch of people saying, "I hope it gets online soon." So we certainly find that once people are accustomed to using it, they really miss it, and no one ever said, "I'm so glad we're back in the paper world for even a few hours." They're very happy to get it back online when it's there.
The Concordia Health Connections Clinic in Winnipeg has been using an electronic medical record since 2007.
Some of the positive impacts of my daily life using the EMR is increased efficiency. So, to give you an example, when I'm seeing a patient, I have approximately 15 minutes to take a history, do a physical examination, prescribe medications if required, order investigations, and ensure that the patient's concerns are met. That isn't an easy task. And one of the challenges with that is the number of questions that can sometimes come to you as a physician, and you want to do a good job in answering all of them, but again, wanting to make sure that information is easily accessible.
At the Family Medical Center Clinic, Dr. Alex Singer also uses an EMR for his daily practice.
The problem with using a paper chart, as you can imagine, with the large volumes of data that we collect on patients, is this paper chart is difficult to access. It's difficult to find information in this chart, and it gets filed chronologically. There's no other way to file data in an electronic chart. This is where we are currently. This is where we should be. Using something like this, I can go in a clinical encounter and I can talk to a patient and I can access information in multiple different forms. I can search information based on dates, as I do currently, or in a paper chart. I can search information based on a word, based on a lab value, based on any other types of information that's collected, and the richness of that data is tremendous.
The electronic medical record is gaining ground across the province as a tool of choice in physician clinics. Dr. Carol Holmes of the Agassiz Medical Center in Morden has been using an EMR since 1999.
The imaging, like CAT scan, MRI, mammogram, depending on the way you file them, they can be quite easy to find. We have them filed such that I can open up a folder, CAT scan, and I can see all the CAT scans you've had done and quickly look at the results. It's much easier to find things. And there's less chance of duplicating things. There's also the job satisfaction, that I feel that you're doing a better job. Things like diabetes, it's much easier to be alerted to when they should have different tests done, because we have a good system that warns us that they're due for a foot exam and an eye exam. Before, it'd be pretty easy to miss that because they come in regularly, they might have a lot of issues, and you don't get down to some of these basic things.
And I'm not seeing a dramatic number, Muriel. I'm seeing more.
Dr. Lauren Hurst is a dermatologist practicing out of Winnipeg. Using Manitoba Telehealth, he is able to consult with patients around Manitoba, some from as far away as Norway House.
Sometimes the patients will think they have a very minor problem and will often think they don't have time to leave their town or city to come down to Winnipeg for a consultation. So they will frequently put off making an appointment. But when offered telehealth, they readily agree, as they can see in their own city someone at their hospital link up through telehealth and be seen by the specialist. The beauty of that is, what seemingly was a small problem initially can be a very serious problem later, and therefore they are not denied access due to lack of proximity to a large center. I think the ease of access to see a specialist is the #1 reason they like telehealth.
I found it easier for myself, and I would recommend it to my friends and family if they don't like traveling or have to worry about missing days so they don't get paid or having to find a sitter. It's a lot easier than going on to town.
Well, I think one of the things I'd like to say to the referring people, whether it be a nurse practitioner or a family doctor, is that you are not selling your patient short by using telehealth.
eChart Manitoba is a secure electronic system that connects authorized healthcare providers with a summary of your health information. Dr. Tunje Fatoye has been working with the eChart since December 2010. Dr. Harold Nyoff practices at different clinics and hospitals around the province and uses eChart in his daily work to great advantage.
We were the first clinic to go live with eChart on the 6th of December 2010. We serve primarily an elderly population here, and a lot of our patients do not remember the names of their medications or who prescribed them or how long they've been taking them. They generally will talk to you about the little blue pill or the little white pill. But with eChart, we can go on and look at the medication records and the prescribed medications and actually look at it and figure out which medications they're on. It's been very helpful to us all in clinic, because prior to that, we used to spend about 15 to 20 minutes trying to get a DPIN faxed over to us, either from the emergency room or we ask one of our nurses to do it. But you can do this right at the point of care in the examination room. The other thing is that it's been very helpful because very quickly you can look at medication interactions and know what to safely prescribe to your patients. Say, for example, a patient goes to the Grace General Hospital emergency and they get discharged from emergency and they say, see your family doctor in 2 or 3 days. They come here and they tell us they've had blood tests done. It's usually used to be a very tedious process trying to retrieve those blood tests. And very frequently we find ourselves repeating tests because we can't gain access to them. With eChart, we can look them up, find them within a few minutes, And so we save the province and ourselves as a whole a lot of money and time because we have access to those tests. And we only repeat the tests that are necessary rather than just doing a whole panel of tests because we don't have access to what was done a few days prior.
I think that it'd be fair to say that in the north, the technological innovations aren't quite as robust as they are in the south. Often patients don't have access to the internet. In some of the nursing stations, we don't have internet access or even cell phone access a lot of the time. So I think that up north, having this ability to track my patients and look at what's happened to them is probably more of a boost than it is in Winnipeg. But I see that the technology is effective in all regions, really. The younger population almost has come to expect this type of a technology, and so they're intrigued with it, but they're not surprised by it. I find a lot of my elderly patients are very technologically savvy, and often they're quite surprised that this technology wasn't around earlier, and they're quite excited by it. I think that the product speaks for itself. Once we see exactly how we can access medications, immunization records, lab tests, hospital visits, I think it's almost a no-brainer once you start looking at the technology and seeing exactly what it can do for patient care.
Implemented in 2010, the RIS and PACS have changed the way clinicians access and read diagnostic images, such as CT scans, MRIs, and X-rays. Dr. Blake McClarty was an executive sponsor of the RIS and PACS project.
Historically, neurosurgery, say, is based at the Health Science Center. If they wanted to view the images that as a preoperative measure or to assess a patient, they would have to have the images sent over by courier or mail in order to view them. Now it's just done electronically instantly. It also helps us in our productivity in terms of our workflow and management, that they give a work list from the RIS system, the Radiology Information System, directly into the modality, the CT scanner or the radiography unit. The list includes the patient's demographic information and health and identification numbers and so on. So there's no errors with data input, and the technologists can spend their time doing the examination, looking after the patient instead of having to put in all of that data into the CT scanner. Also, the PACS system allows us to convert to a digital environment in terms of the acquisition of the images. So in the case of plain radiography, we can do digital radiography where the images, instead of being on traditional film, are now on plates and are converted instantly into a digital image and instantly sent to PACS. We can search whether the patient has had examinations in other locations in the province, so that if somebody's had an examination in Dauphin, it's all available to us for comparison when they're transferred down here with, say, a cardiac condition or something. Our turnaround time is much improved too with PACS because the images are available, and if those ones, in the past, if the film were in emergency, we wouldn't be able to interpret them formally because the emergency doc was doing it. We might see something that the emergency doctor missed, and now because the images are available to us at the same time, we're quicker in terms of getting the reports to emergency and so on. And the RIS is fantastic for that because the actual typed report, even before we sign off and sign on it, is available to the physicians as a preliminary report as soon as it's typed. And that can be within minutes of the examination being completed. The thought of going back and interpreting on the basis of films, none of us would want that. It's been a remarkable increase in time. The transition's been, of course, a little bit difficult, but no one would vote to go back and remove the PACS system and go back to the way we were doing it. It's just not even, it's been a remarkable change in the way we practice, for sure.
Dr. Ricardo Labada da Faria is the Chief Medical Officer and Executive for Emergency Medicine at Seven Oaks General Hospital in Winnipeg.
When we introduced this, we weren't sure what the results were going to be. Very early on, we saw a very positive effect. One of the things that happened is the patients left without being seen number diminished greatly. So people now knew how long the wait was going to be. They In the past, they wouldn't have known, was it 10 minutes, was it an hour? Now they knew, and they can make the judgments accordingly. So what we did find is that we halved the amount of patients that were left without being seen. So whenever a patient looks at the board, there are a few indicators they can actually see. They can see how many patients are in the waiting room. They can see what is the average waiting time and essentially the range of how long the wait is. So from so many minutes to so many minutes, or from 1 hour to 2 hours, whatever the wait may be. And this way they know that their wait is likely to be in between those two waiting times. One of the things that we have found is now that we have these patients waiting, we essentially have a captive audience. So this is a great opportunity for us to give health promotion advice, to promote services that are offered to the patients. And what we are hoping also is to improve the patient experience, to orientate them as to what the wait is, what to ask for before they get discharged. So this is only the beginning of a much better service that will be coming through the emergency departments.
Since 2001, the WRHA Home Care Program has been using the RAI-HC clinical assessment tool to assess the health status and care needs of clients and to guide comprehensive care and service planning.
My name is Barb Kirk. I'm a case coordinator with the Community Stroke Care Service. Good. How are you today? Good, thank you. Good. One of my goals as a case coordinator is to do a thorough assessment on my clients. And the RAI-HC tool is an assessment tool that allows me to assess multiple aspects of my client's functioning. And how have you been managing? Because of the electronic record, then I'm also able to see the differences, whether there's been an improvement, a decline in a client's function easily by using aspects of the RAI tool. I have been using the RAI-HC tool for approximately 10 years. Prior to that, we had used a paper tool when we assess clients. Because it was a paper file, you actually had to have the specific file to get any information. And now it's a consistent assessment, it's standardized amongst all the case coordinators so that we are all doing the exact same assessment, which is a big benefit. The RAI-HC assessment tool is a support for case coordinators doing clients assessment. However, the case coordinator's clinical judgment is still essential in all aspects of the client's care. It helps with my workload, and it also just the ease of finding information and being able to access client information quickly, and which helps me, improve care for my clients.
I'm Dr. Lori Mitchell. I'm a researcher with the Winnipeg Regional Health Authority Home Care Program. The inter-eye assessment system for home care that we use in the WRHA Home Care Program, we commonly refer to as the RAI-HC. And the RAI-HC is a clinical assessment tool that collects information on our home care clients. There's over 300 items that are collected with the tool. And it's a comprehensive assessment system that provides the clinician, our case coordinators, a wealth of information about the client they've assessed, and it helps to assist them in the care planning for the client afterwards. Once the case coordinators have collected that information electronically, that creates for the program an electronic database that then at the aggregated population level, I'm able to use that information for research, for program monitoring, for evaluation, and use that information in many different ways to support the program for planning and policy development. In a given year, I've got over 13,000 assessments to draw on for analysis and research purposes. Before this database was available, the kind of research that I do wasn't even possible. One of the important aspects of the database that I find for the program is how we use it to monitor quality within the program, because there's embedded quality indicators that come out of the data. And that's been very important for us to use that information to take a look at potential quality issues that we need to address, and that therefore has an ultimate impact on the quality of care that's being provided to our clients.
That's very good. And Gloria, is that right?
Manitoba eHealth continues to work with healthcare providers to offer more ways for patient information to be available to the right person at the right place at the right time. The journey continues.